The following podcast is part of a certified educational activity titled Innovation Takes the Lead in Small Cell Lung Cancer, Leveraging Evolving Advances to Drive Improved Outcomes in Limited and Extensive Stage Disease. Access the entire activity and complete the post-test at peerview.com/PYJ860. Downloadable slides and practice aids are also available.
Thanks for joining us for this PeerView Live program. Innovation takes the lead in small cell lung cancer, leveraging evolving advances to drive improved outcomes in limited and extensive stage disease. My name is Stephen Liu. I'm the Chief of Hematology and Oncology at Georgetown University, and I'm pleased to be joined by two of my thoracic oncology colleagues from Emory University, Dr. Jennifer Carlisle, and from Dana-Farber and Harvard Medical School, Dr. Narjust Flores. Our goals for today: to learn how and why key therapies are transitioning to earlier stages in small cell lung cancer, to limited stage, to the maintenance setting, what factors inform individualized treatment selection and sequencing, and how to navigate some of the logistical challenges and practical barriers to implementation of the treatment strategies best for our patients. As all of us in this room and at this meeting know, small cell lung cancer is a very challenging cancer, a very difficult space for drug development. Historically, this has been a smoking-related cancer with smoking-related comorbidities and a very rapid clinical course related to the biology of small cell lung cancer, which does not leave time for trial enrollment for large biopsy specimens, at least historically. Chemotherapy, platinum etoposide, easy to deliver with initial responses, but we know those responses are very transient. We also have a limited understanding of the biology, and our preclinical models were not entirely reflective of the patients that we're treating in the clinic, but we are finally making progress. While platinum etoposide was our chemotherapy of choice since the 1980s, it took almost 40 years to see any survival gains. Those initial gains came in the form of immunotherapy, atezolizumab in 1919, durvalumab in 2019, durvalumab in 2020 approved, and then we saw later line agents like lurbinectedin and tarlatamab. In December 2024, the integration of immunotherapy to limited stage small cell lung cancer with durvalumab in the Adriatic study, and then this year, just within the past few months, the approval of lurbinectedin and atezolizumab as maintenance treatment, and tarlatamab's full approval as a second-line standard of care. So we'll now move into our discussions, guidance on modern small cell lung cancer standards, personalizing sequential care and preparing for emerging approaches. With that, it's my pleasure and privilege to introduce my colleague from the Dana-Farber Cancer Institute and Harvard Medical School, Dr. Narjust Flores, to talk about limited stage small cell lung cancer. Narjust?
Thank you so much, Stephen. It's my pleasure to be here with you. I hope food is good. We're going to talk about limited stage small cell lung cancer. Limited stage small cell lung cancer was dormant for rather some time until the latest years. So let's start with that case. So we have Maria that was diagnosed with limited stage small cell lung cancer. She presented with a cough that was worsening over 2 weeks. She has history of hypertension and COPD. A follow-up CT scan showed this 4-centimeter lobulated left upper lobe mass. We associated hilar in mediastinal lymph nodes. MRI was negative for metastasis, and the PET scan was negative for systemic disease. Maria comes to clinic, and then we start talking about treatments for this limited stage small cell lung cancer. So let's talk about the treatment. So limited stage small cell lung cancer is the minority of the patients with small cell. Approximately 30% of these patients, and limited stage is stage 1 to stage 3, and it's usually one lung, one side of the chest. It's an urgency of diagnosis. These patients need to start treatment rather fast, and they tend to have poor prognosis. Around 15 to 20% of patients are alive at 5 years with the standard treatment, which was chemoradiation followed by observation, with many of them having systemic disease progression. Things changed with Adriatic. So Adriatic was presented in 2024 ASCO, which is for a limited stage small cell, echo performance 0 to 1. Patients had no progress in chemoradiation, and PCI was permitted. Patients were rated stratified by stage and the PCI or not, and you could have radiation once a day for 60 gray or radiation twice a day for 45 gray. The 3 arms were durva versus placebo plus durva plus tremelimumab. We're going to focus on the durva versus placebo. The patients go durvalumab for 24 months or at the time of disease progression or significant adverse event. What do we have? We have longer overall survival. These are patients with chemoradiation, followed by durva for up to 24 months. We have median overall survival for the durvalumab arm of 55.9 months. This is a small cell, right? These numbers don't sound like a small cell. And 33.4 months for the placebo arm. So significant benefit and overall survival. We're talking about over 20 months. Progression-free survival was also significant for the patients that have consolidated durvalumab, 16.6 versus 9.2 months. We're talking around 7-8 months. Difference here, the curves start separating rapidly, right? After the chemoradiation is completed, and then we can see the difference between the patients that went into placebo versus the consolidation immunotherapy. Safety profile. One of the things is that the median number of doses, around the range of the median was 9. There was no significant differences in the maximum grade 3 and 4 effects, side effects between durva versus placebo, around 24%. Serious adverse events were higher in the durvalumab, but only for a few percentages. There were adverse events that led to death that were treatment-related, around 2 in the durvalumab arm. However, immune-related adverse event is something that we are familiar with now. In this graph, we can see which immune-related adverse events. And some of the concerns we have initially was, can immunotherapy increase the risk of pneumonitis? And these patients that already go 60-grade or radiation. There were no significant differences between placebo and between immunotherapy for the risk of radiation pneumonitis. Decreased appetite was very similar. What was different? The side effects of the endocrinopathies from the immunotherapy. So higher percentage of hypothyroidism, hyperthyroidism, rash, pruritus were more common on the durvalumab arm. But all these adverse events are something that we are familiar with. It is not my role to say what is tolerable or not, as the patients, but we are very familiar with how to manage many of these adverse events. So we always try in oncology to see if more is better. Can we include immunotherapy with the chemoradiation? And that's what the NRG Alliance Lung 005 tried to do. So chemoradiation with immunotherapy followed by consolidation. Unfortunately, it does not improve the overall survival. So incorporating the immunotherapy early in the course did not make a difference. The study was negative, similar to what we saw in PACIFIC-2 for non-small cell lung cancer with the incorporation of immunotherapy at the same time of chemoradiation. However, I do believe there learn lessons for all trials. Even if the overall survival is negative, we learned that it is not that toxic to give immunotherapy with radiation at the same time. So then things are moving in early stage, and we cannot talk about small cell without talking about tarlatamab. And this is Delphi 306. It's a phase 3 study that our patients with limited stage that are going to be randomized to tarlatamab versus placebo after completing chemoradiation. Different compared to Adriatic, patients in Delphi 306 get 12 months of tarlatamab versus 24 months with durvalumab, and the patients are going to be followed for end of treatment and long-term follow-up. So tarlatamab, you're going to hear a lot in the extensive stage, but it's also permeated to the limited stage now. So what are the take-homes we have for immunotherapy in limited stage? First, it was time to bring immunotherapy to limited stage for a small cell. We have seen that this is the new standard of care. After chemoradiation, the patients that had no disease progression, you give them time to recover. You will start durvalumab every 4 weeks for these patients for approximately 24 months. At least there is disease progression or a significant adverse event. It should be given after. No, with chemoradiation, there is no benefits in survival or adding the immunotherapy to the chemoradiation. Biomarkers, we still don't have great biomarkers in this stage. The PD-L1 still doesn't have a role here. However, as data is moving, we're learning how to differentiate a small cell in different subgroup categories. Dr. Sen is doing a lot of work on this. Uniqueness about Adriatic compared to Pacific is this is 2 years of immunotherapy. There are a lot of ongoing trials for limited stage small cell lung cancer, but to have more patients with limited stage small cell lung cancer, we need to remember that is a correlation or association with lung cancer screening. The majority of patients with small cell lung cancer had previous tobacco use, so to get more limited stage, we had to do more lung cancer screening. So let's go back to the case with Maria. The patient is started treatment with chemoradiation. She tolerated chemoradiation, so adverse events, maximum supportive care with hydration and antiemetics, and she proceeded with immunotherapy. So we'd like to discuss with the panel a few questions. When you have a patient with limited stage small cell lung cancer, how do you bring the treatment options? There's not that many. We have one. When you bring it to the clinic. Jennifer, how will you have the conversation with Maria?
I think it's important to work closely with our radiation oncology colleagues because we really want to start concurrent treatment promptly. And similarly, with our radiation oncology colleagues, we need to discuss whether or not to consider prophylactic cranial radiation. The limited stage setting being the primary one we think about this, but it's still also very patient dependent.
So, Stephen, to that same question, but then I'm going back to the PCI because that's very controversial. So how do you present treatment options to patients with limited stage?
You know, this is an overwhelming diagnosis, and I think up front, it's important, as mentioned, to discuss with our radiation oncologists, because what's unique to this functional staging system is that beyond TNM, the tolerable radiotherapy port is something that we can only define knowing the breathing function, knowing the radiation fields that are involved. And if it truly is limited stage, this is a window where generally patients are diagnosed in later stages. So if we do have a limited stage, we want to move in early. We like to start concurrent chemoradiation fairly quickly, but if there's any delay in radiation, insurance, transportation, logistics, we'll start with chemotherapy right away, fold in radiation with cycle 2. And I think the first question is once daily versus twice daily. It's our preference twice daily, not always possible. Once we get past that initial therapy, prophylactic cranial radiation in older studies was shown to decrease the risk of brain metastases and improve survival in both limited and extensive stage. What we know now from a lot of more modern studies in the MRI era, we're calling into question that survival benefit. I think it is still standard of care. It would certainly be my board answer, but I think in practice, I think it's a discussion with patients because that radiation does come at a cost. We worry about that cognitive deficits and long-term toxicities. There are important ongoing studies like the Maverick trial that I think will really help answer that question. So that's a discussion we have as a team together, but certainly in this setting, after concurrent chemoradiation, not with it, as you pointed out, durvalumab I would consider really the standard of care then.
So going on the PCI, Jennifer, who are the patients that you highly consider for PCI with limited stage?
Not to be ageist, but I think age matters a lot in terms of the risk of cognitive side effects. So in the younger patients, they can tolerate whole brain radiation a little bit better than those in their latter decades. So I think that's important. If patients have, already diagnosed dementia or some cognitive decline, that would make me really question whether or not it would benefit that patient.
I think regardless of the decision of PCI, we need to continue to monitor CNS closely. Patients that have PCI, we're allowed to go in the Adriatic. And my last part as we come here is the importance of talking to radiation. Most patients will get the first cycle before radiation, but the conversation with radiation should start even before that first cycle. It takes simulation, it takes time in the machine. So I think it requires a lot of multidisciplinary care for these patients, and we cannot forget a very important part, this is my last comment, about tobacco cessation is also an essential part for these patients in their care that should not be forgotten. And it is my pleasure to invite Dr. Liu to the podium.
Thanks, Arju. So limited stage small cell lung cancer is an area where we have an opportunity to provide long-term control and hopefully cure for some patients. And we expect and hope this number goes up with more awareness, with lung cancer screening. However, the biology of this disease is changing a bit. In more recent phase 3 trials, we see up to 20% of patients have no history of smoking, which would really not be captured in our screening. So most patients are going to present with extensive disease. So how do we manage extensive stage small cell lung cancer? Here's our case number 2. Thomas, a 75-year-old man with a history of hypertension, COPD, hyperlipidemia. Presents with a cough, has an x-ray that shows an abnormality in the left upper lobe of the lung. A CT scan reveals a 4-centimeter left upper lobe lung mass with regional and mediastinal adenopathy. Bronchoscopy establishes a diagnosis of small cell lung cancer. MRI shows no metastases, but our PET CT unfortunately does show spread to the bone, to the liver. This extensive stage small cell lung cancer, I think a fairly typical presentation. In the 1980s, we saw the introduction of platinum etoposide. That was the Carter administration, and it took us 40 years to really see any changes that led to an improvement in survival. That came in the form of immunotherapy. In 2018, we saw the results of adding a PD-L1 inhibitor to frontline induction chemotherapy that improved PFS, improved overall survival. In 2020, we saw a second regimen approved. Those were atezolizumab and durvalumab. And that second-line setting for patients that did relapse, we had topotecan, lurbinectedin in 2020, tarlatamab in 2024. We are now witness to changes in that treatment algorithm, where now our frontline options would include chemoimmunotherapy with lurbinectedin maintenance, a clear second-line standard with tarlatamab, and the third-line setting, topotecan, lurbinectedin, but newer agents right around the corner. So the field is changing, and for those at home and online, you can download the practice aid in the top right to really see this in action. Our frontline treatment options changed with the FDA approval in 2019 of atezolizumab in the frontline setting, followed in 2020 by Caspian. Two different studies with different designs, but the same results. Platinum etoposide immunotherapy for 4 cycles plus immunotherapy improved outcomes. The Caspian study, a 3-armed open-label trial looking at durvalumab. And really the addition of durvalumab to platinum etoposide improved survival. And with longer follow-up, we see at 3 years a survival rate of 17.6%. Compare that to 5.8% in the control arm. And the first study, Empower 133, presented in 2018, the addition of atezolizumab to standard carboplatin etoposide improved PFS, improved overall survival without significantly increasing toxicity. We established a new standard of care when this was approved in 2019. And we saw with 5-year follow-up in the Umbrella A extension study, a 5-year survival rate of 12%. These are game changers. These are our standards of care. And while that 12% survival rate at 5 years is not as high as we want it to be, it is certainly higher than what it was. We now see in my practice, we see in our clinics, long-term survivors. And I think what these advances offer is hope in a disease that largely was felt to be highly lethal with a survival of only 8 to 9 months with chemotherapy alone. Now we have some patients that are alive 5 years longer. We have patients that are long-term survivors in our clinics. This is clearly an advance. This is our standard of care. But at the same time, we can endorse that and still understand that we need to do better, that most patients, despite this advance, will relapse and will die from their disease. And so how do we make improvements? When we think of second-line treatments and beyond, while we have exciting advances in later lines, we also know this is an unforgiving disease. If we look here at this graph, 100% of patients who receive frontline therapy, out of those patients, only 50% would receive any second-line therapy, and only 22% would receive any third-line therapy. Real-world studies are very similar, if not worse. Most patients do not receive more than 1 line of treatment, despite availability of drugs. Why is that? Well, the active progression for small cell lung cancer can be so violent, can be so unforgiving, that patients are often rendered too ill to receive any other therapies, or in the worst case, they don't survive that act of progression. If we have a very effective treatment, the only way to promise our patients that they'll receive it is to move it earlier, is to give it right away. And this was in part the rationale for the IMforte study, a randomized phase 3 trial looking at the value of maintenance lurbinectedin for patients with extensive stage small cell lung cancer. And here's our study design. This included patients with no prior systemic therapy for extensive stage small cell lung cancer, excluding patients with brain metastases. All patients received standard carboplatin, etoposide, and atezolizumab for 4 cycles. And at that point, they are rescreened. If there is no progression and if performance status still permits, they are then randomized to standard maintenance atezolizumab alone or maintenance atezolizumab plus lurbinectedin, given at a dose of 3.2 mg/m squared with primary prophylaxis using GM-CSF. Primary endpoint here, PFS and overall survival. So what do we see here by moving lurbinectedin up? The overall population was very similar. I'll point out that there were younger patients in the lurbinectedin and atezo arm. If we look at the rate of liver metastases, 40% in both arms. This is a high-risk population. And that third of the bottom arrow, 3.2 months from induction to maintenance. The numbers I'll show you were measured from the time of maintenance. They don't include that 3.2 months of induction therapy. But when we move lurbinectedin up earlier, when we give it before progression in a proactive manner, we improve progression-free survival. We significantly improve PFS from 2.1 months with atezolizumab to 5.4 months with lurbinectedin. At 6 months after completion of induction, with atezolizumab alone, only 19% of patients are still progression-free. With the addition of lurbinectedin, we move that to over 41%. The hazard ratio here for PFS, 0.54. Again, if we look at the absolute number, 5.4-month PFS from maintenance. If we include the 3.2 induction, that puts us at 8.6 months from the time of cycle 1, day 1. We are extending progression-free survival. But I would argue we would expect that. Lurbinectedin is an active drug approved in that second line. We're moving it up earlier. We expect to see an improvement in PFS. We expect to see that come at the cost of more toxicity. The big question is, does that translate to people living longer? And it did. We see an improvement in overall survival, moving from a median of 10.5 to 13.2 months. That's a median survival from cycle 1, day 1 of 16.4 months. The 1-year survival rate, 44% to 56%. These survival curves split quickly. That separation is maintained. And the OS hazard ratio, 0.73. If that looks familiar, that's the exact survival hazard ratio of Caspian, the exact survival hazard ratio of Adriatic, 0.73. Enough to change our standard of care. Remember, that median number is measured from the time of maintenance, not from the time of induction. We would add 3.2 months to account for that. So from cycle 1, day 1, patients here in this study, a median of about 16.4 months. We're adding an active drug. More treatment means more toxicity. Not to be discounted, we do see higher rates of grade 3-4 adverse events. And while, as Narjus pointed out, tolerability is in the eye of the beholder, if we look at how often does toxicity lead to discontinuation of treatment, how often do we have to stop treatment due to adverse events? 6% with lurbinectedin and atezolizumab, compared to 3% with atezolizumab alone. Toxicities are what we expect with lurbinectedin, primarily myelosuppression. We can see nausea, fatigue, but it's anemia, thrombocytopenia. These are largely grade 1, 2. I'll call out that box in the top right. G-CSF is recommended primary prophylaxis to reduce the myelosuppression with this agent. Updates from a few weeks ago at ESMO show that when we look at progression in target lesions, it is less with lurbinectedin and atezo. Most progression really is with new disease. And if we look at who is benefiting from this strategy, patients with a CR versus patients with a PR versus a stable disease, really it was across the board, all patients deriving similar benefit from this maintenance strategy, from this earlier integration of more cytotoxic therapy. Field continues to evolve. We mentioned tarlatamab, a bispecific T-cell engager. This is also being studied in the maintenance strategy. Here in the maintenance setting, the use of tarlatamab with atezolizumab or durvalumab showed very encouraging 1-year survival rates. I will acknowledge this is a very selective population, and we will see a randomized study, the Delphi 305, which will explore tarlatamab in that maintenance setting versus standard of care, and does that improve outcomes. So coming back to our case here, Thomas was a 75-year-old male with extensive stage small cell lung cancer, no brain metastases, but metastases in the liver and the bone, a performance status of 1. Let me turn to my panel here and start with Narjus. Which regimen do you think would be right for Thomas, and what are you thinking of when you're choosing which regimens to give our patients?
Well, I think what is important is the goals of the patients, what the goals of the therapy. This patient, I'm going to assume, that's motivated for systemic therapy. So I tend to use the traditional chemoimmunotherapy induction regimen, and then there is a stop. We stop and reconvene after. I think for patients to make decisions about maintenance therapy at the time of diagnosis, it's different. You haven't got chemo yet. You don't know what you're dealing with yet, right? So then after induction is completed, we have another checkpoint. What do you think about doing the atezolizumab and lurvi? I have 2 patients right now in the maintenance, and it has been an ongoing conversation even there. However, understanding how aggressive the disease is and all that may require for some of them in second-line therapy, more and more patients are very interested in this maintenance therapy or immunotherapy for lurvi. It has been widely adopted in not my practice, but all my colleagues as well.
Jennifer, how do you look at selection for a maintenance lurbinectedin approach?
Yeah, I agree with Nargis that it's patient dependent. I've had patients that tend to be a little older and frailer since this was available, and I've had patients choose not to do maintenance lurbinectedin. But again, I think, like you said, it needs to be continually reevaluated, and with supportive care and kind of upfront discussions throughout the treatment course, we're seeing more and more of it.
I think that this is very reminiscent to me of that Pacific regimen. And when we look at maintenance strategies, I think it's important that we not overwhelm the patients up front with too much information, but I do think there's value in getting a glimpse of the big picture. And so in the older days when we give chemoradiation alone for a stage 3 non-small cell lung cancer, after you finish that fairly grueling treatment, to then say, now we're going to do a year of durvalumab, that's not so well received. We need to mention that up front. I think the same is true here. And so when I have a patient come in diagnosed with extensive stage small cell lung cancer, we'll give chemotherapy. We actually expect patients to feel better. Tell them early on, this first phase will be 3 medicines, 2 chemotherapy drugs and immunotherapy every 3 weeks. And after that, if all goes perfectly, if we have a good response, good control, patients feel well, we will then scale down from 3 drugs down to 2 drugs. And so replacing platinum etoposide with lurbinectedin, still staying every 3 weeks. One of the questions we're seeing, and there are several coming in, do we give these drugs on the same day, or do we sequence them one after another if infusion times are tight? Jennifer, what's your strategy here? Do we give atezolizumab and lurbinectedin together?
Correct, yeah. Our infusion center is tight. To split that over days would be even more difficult.
Absolutely. So we do want to align those, and I think a good call out from online is, reducing the risk of nausea. This is a cytotoxic agent, so we do want to think about primary prophylaxis for nausea, not just for myelosuppression. So I think anticipating this, but patients are really coming off a fairly toxic regimen. When we look at the side effects, it really is more driven by the chemotherapy piece.
I tend to be very aggressive with the nausea management, but before I start that, I think something that we forget is to do a very good drug reconciliation in these patients. A lot of these patients have many comorbidities. We have hypertension, COPD, hyperlipidemia, and many other things. So I do a very good med-rec. Sometimes these drugs are inducing the nausea as well. We have a plan. My nurse practitioner and I, we call it the triplet, so 1, 2, 3, and what to do at what type of nausea. So they have this auction, and I like to print it, and I ask them to put it in the fridge. Like some people put the pictures of the drawing of their children, and like your anti-nausea regimen is going on the fridge. And other alternatives besides drugs, ginger is something that we underutilize for nausea control. Acupuncture has been very helpful, and to be active. It really helps with a lot of these side effects as for these patients to move. So that's also part of my treatment for the nausea. I was like, go out. I know we're in New England, but go out.
And I'll address one more question from online, I think a good one. How does lurbinectedin impact later line therapies? And we don't really think it'll have an impact. Your second line regimens would still be your second line regimens. Here we're moving something up before progression earlier on. The only exception is if you're using lurbinectedin in maintenance, you won't be able to use it later lines. But we've learned again from these high attrition rates that we can't save drugs for later use in this disease. It's just not practical, just doesn't allow it. And so at that point, talking about second line and talking about some of the newer DLL3 targeting bispecific T-cell engagers, I want to welcome Dr. Jennifer Carlisle from Emory University to talk a bit about that. Jennifer?
Thank you so much. We'll start with a case. This is James, a 65-year-old diagnosed with extensive stage who started on standard platinum doublet durvalumab, had some delays in initiating cycle 3 and 4 due to slow count recovery, and unfortunately after 2 cycles of durvalumab developed progressive disease with new hepatic mets and 3 sub-centimeter brain lesions. Fortunately, his performance status is preserved, and he says he wants to be as aggressive as possible. This is somewhat of a historical slide going back a couple of decades for this data. Really until 2020, this was our salvage regimen. You can see here the bar was pretty low, a marginal benefit over best supportive care. Then in 2020, we saw the approval of single agent lurbinectedin in the second line setting. This trial allowed patients with up to ECOG performance status of 2. It did exclude patients with brain metastatic disease. And we can see here on the results that there was kind of a differential response based on platinum sensitivity. The cutoff used here was a chemotherapy-free interval of 90 days. In patients with platinum-sensitive disease, the response rate was 45%, with a median PFS of 4.6 months, median OS 11.9 months. This is significantly better than the data with topotecan. But in the chemotherapy-free interval of less than 90 days, the platinum-resistant patients, our response rate was 22%, median PFS 2.6 months, median overall survival 5 months. So then came the advent of T-cell engagers. Here's a kind of standard schema where we can see a CD3 targeting arm which binds to the T-cell receptor. And when the target antigen binding site is activated, we get prolific T-cell proliferation as well as release of perforin and granzyme leading to tumor cell lysis. I skipped over the kind of initial tarlatamab studies to really show the newest data we have, which was presented at ASCO 2025, looking at Delphi 304. This is the confirmatory trial designed to look at second-line tarlatamab versus physician choice of chemotherapy, a 1-to-1 trial of over 500 patients. This did allow patients with asymptomatic treated or untreated brain metastases, and physicians had to list what their intended chemotherapy was: topotecan, amberubicin, or lurbinectedin, and the primary endpoint was overall survival. First, here you can see a significant benefit in progression-free survival. Tarlatamab median PFS was 4.2 months compared to 3.7 months. Hazard ratio is 0.7. The response rate was higher with tarlatamab at 35% compared to 20% with chemotherapy, and a longer duration of response, median 6.9 months with tarlatamab compared to 5.5 months with chemotherapy. The primary endpoint was overall survival, and here you can see a separation of curves before 3 months that is maintained. Median OS 13.6 months with tarlatamab compared to 8.3 months with chemotherapy. These are the pre-specified subgroups with benefit of tarlatamab seen across age, gender, PD-L1 exposure. I think it's important to note the patients who are platinum resistant with a chemotherapy-free interval of 90 days. We saw a benefit of tarlatamab, as well as patients with previous or current brain metastases. I think it's also important to note that this was a global study, and the choice of chemotherapy favored topotecan and amberubicin, with about 200 patients in that arm compared to 47 in the lurbinectedin arm, and that bar has a wider confidence interval. Looking at safety, while there is certainly all-grade treatment emergent adverse events in both arms, if we drill down into the more severe treatment-related grade 3 or higher toxicities, we can see almost double the toxicity with chemotherapy than tarlatamab. Looking at serious treatment-related AEs, that was about equal. Dose reductions or interruptions were lower with tarlatamab than cytotoxic chemotherapy, with low rates of discontinuation or grade 5 events due to the treatment in this very lethal disease. We could see now with 500 more patients confirm previous reports of ICANS and CRS rates. So while 56% of patients developed cytokine release syndrome, this was in the vast majority, 42% grade 1, with 13% grade 2, 17% serious cytokine release syndrome. The rates of ICANS, or immune effector cell associated neurotoxicity, were low, 6% overall, half were grade 1, only 4% were deemed serious. And I think on the right, it's something we can discuss as a group, but how do we best monitor these patients? The majority here had the standard, a long admission of 48 hours compared to a 6 to 8 hour monitoring cohort. And we're seeing that the lower monitoring does not necessarily increase the risk of low or higher grade adverse events, but we have to be diligent and thoughtful in how we kind of incorporate that in our treatment practice. We have other agents that are in active development. Obrixtamig is another bispecific T-cell engager targeting DLL3 and CD3. This is being investigated outside of just small cell lung cancer, looking at extrapancreatic neuroendocrine cell carcinoma and large cell. In updated data, we can see duration of response of 8.5 months. Similar rates of cytokine release syndrome. This notes dysgeusia in 23%, and I think it's a big problem for patients who are doing well on tarlatamab and tolerating therapy, but things just do not taste good and they don't want to eat anything. So this is certainly a problem we need to try and address in terms of supportive care. They have an ongoing DARIEN-8 frontline trial, adding obrixtamig to the backbone of platinum, etoposide, and immunotherapy. We also have tri-specific T-cell engagers. One not shown here, gocatamig, has a albumin binding domain. This ZG006 actually has 2 domains that target different epitopes of DLL3, as well as the CD3 binding domain. Here's a phase 2 dose finding study looking at 10 milligrams every 2 weeks versus 30 milligrams. And response rates were very similar between the 2 groups. This is a very early study. There's only 3 months of follow-ups. We await further information on that. I'm going to breeze quickly through some of the safety and dosing considerations with the currently available tarlatamab. Here's the standard grading for cytokine release syndrome that we stole from our hematology colleagues and has been useful in patients with small cell lung cancer. Grade 1 is typically just fever, whereas grade 2, patients may develop hypotension or hypoxia and then get more severe, require more intense supportive care. Here's the step-up dosing regimen where we start with 1 milligram on day 1, followed by 10 milligrams on day 8 and day 15, and then every 2-week dosing of tarlatamab. Patients get 8 milligrams of dexamethasone before these first 2 doses, and the FDA package insert recommends appropriate healthcare setting monitoring for patients for 22 to 24 hours to look for CRS and be able to intervene quickly. We have found that cycle 3 and beyond, the risk of side effects are very, very low. So personally, we don't do a lot of monitoring for 3 to 4 hours for patients in that setting. Although I think it is really important to note if there is a treatment delay and patients are without that antibody for a long enough time, you do need to reinitiate step-up dosing as the risk of CRS comes back. Here is a management approach. Again, I'm not going to walk through every line of this table, but it's available for reference. Supportive care for grade 1, and then as we get to grade 2, we're using dexamethasone, maybe tocilizumab, certainly monitoring in the hospital. This is because immune effector cell-associated neurotoxicity syndrome, or ICANS, can be pretty wide-ranging in how it presents. These T cells can cross the blood-brain barrier, as can the inflammatory cytokines and chemokines, leading to confusion, disorientation, balance issues, motor weakness, aphasia. I personally haven't seen seizure or much cerebral edema, which we see with other T cell engagers for other malignancies, but we need to be mindful of that. And that includes careful assessment. The immune effector cell-associated encephalopathy, or ICE score, is what's most commonly used, looking at a number of neurocognitive parameters. And as this score goes down, we need to add interventions, steroids, and potentially other workup for what might be going on. Here's the management table for ICANS. And I'll just jump straight to some of our rescue medications. Tocilizumab is an IL-6 receptor antagonist, but it's important to note that there's poor penetration of the blood-brain barrier. So really for ICANS, we need to move to corticosteroids as our backbone. We have another IL-6 antagonist, siltuximab, that may be an alternative for tocilizumab, and then an IL-1 antagonist that can be used if refractory, including patients who have CRS with ICANS. So jumping back to the case, I'll pose it to our panel. What second-line treatment would you recommend for this patient who got chemo immunotherapy without maintenance lurbinectedin?
I think the patient rather had disease progression fast. suggesting that chemotherapy is not really what we used to call chemotherapy sensitive. So we have to find an alternative pathway. Immunotherapy didn't hold the disease more than 2 cycles, so that's 8 weeks. So getting out of the box and use new agents with tarlatamab, I think tarlatamab has changed how we treat small cell lung cancer in extensive stage, being gladly surprised for some of the responses that we'll expect in second-line therapy. So my choice will be that. The patient still has a preserved performance status, interested in pursuing treatment. As soon as we have a good discussion about what requires at the beginning of tarlatamab, I think that would be my recommendation here.
Yeah, I agree. This is someone that should move on to tarlatamab fairly quickly. When we think about how the drug works, it's going to work probably a little bit better when your ratio of molecule to cancer cell is a little more favorable. So this is a molecule that's going to be a little more effective, a little better tolerated with lower disease burden. You don't want to lose control too far. I think you got to go quick here to a drug like tarlatamab. In addition to changing sort of the standard of care, it's also changed how we think of relapse. And right up until the full approval of tarlatamab, the NCCN guidelines really branched off based on chemo-resistant versus chemo-sensitive. And with these data, that went away. And as you pointed out here, we saw favorable outcomes for both platinum-sensitive and platinum-resistant. I think tarlatamab is our immediate choice here, moving right into it.
I think something about tarlatamab is the duration of response. The patients that respond, in my experience, have a prolonged duration of response that these patients did not have with the previous agents.
And just speaking personally about patients responding to tarlatamab, I've found in a very small number of patients, we are able to kind of salvage response with isolated radiation. If, say, there's a CNS progression on tarlatamab, it's a different biology now, using that bispecific T-cell engager, and sometimes able to use selective radiation to keep people on this drug.
I think that probably happens a little more than we realize. And when we look at these data, while the randomized trial is very impressive, it's hard not to comment on a pretty big disconnect. The PFS benefit, while statistically significant, is very modest. And what you really do see is an exaggerated OS benefit. I'm not sure we totally understand why there's that discrepancy. We welcome it, because we certainly want to see better survival here. But the PFS benefit is a lot less significant than the profound OS benefit.
In either of your practices, what are you thinking about moving towards like an outpatient administration and monitoring, either with like advanced diagnostic tools at home or on-call services, or is there a way you guys are thinking about administration for the first couple of cycles with a high risk of CRS?
Yeah, I think personally that package insert is very conservative, and I think that having someone monitored for 4 hours in cycle 3, I think is probably not practical. Most of our infusion units are very busy, and so I don't know that that's entirely necessary. As you mentioned, these toxicities are very front-loaded. You see them early on, and so I do think that as we gain a little more comfort with monitoring, maybe with devices, maybe home hospitals or outpatient observation settings, that we'll be able to scale that back a little. If you follow just the package insert with an overnight admission for day 1 and day 8 with really sort of very long observation periods, I think it's going to be very impractical for patients to receive this treatment, especially if they live very far from the hospital center where it's delivered. I think that as we sort of do more work on monitoring, like work that you've done and presented at ASCO, I think that we'll be able to improve access to these drugs.
And just to add that, something that Dana-Farber was one of the first sites to adopt tarlatamab, but New England is so large. So what we did is develop relationships with local oncologists in which the patient would come to initiation of therapy at the hospital, and then they will get the first, second cycle. As things go back, then they will go back home. So I think that strengthens the relationship of the large academic center with small practices as these new agents are coming in which the patient doesn't stay at the academic center but goes home, where quality of life is better. Doesn't matter if you stay at the Ritz, your bed is your bed.
Yes. Right? And I think that does get patients plugged in for clinical trial down the road at relapse if they've already established care with their kind of regional center.
We're going to close with just a few slides on what's next and a preview of what this discussion would look like next year. And really where we see the most excitement is with antibody-drug conjugates. In addition to T-cell engagers moving up earlier into therapy, we really do believe that these ADCs are going to be impactful in this setting. DLL3 ADCs had a rough start with rivalpatuzumab tesirine, which was just too toxic of a drug that was more based on linker technology and payload. With newer DLL3 ADCs that we've seen at recent meetings, we're seeing very high response rates, much more favorable therapeutic windows. CD56, TROP2, SEZ6 as emerging tumor-selective targets, but B7-H3, I think, really the furthest along with some of the newer agents, and I'll call out in particular ifinatamab deruxtecan, or I-DXd. This B7-H3 ADC with a topo-1 payload has shown very promising activity. If we look at the ID8-Lung01 study, here we see response rate overall of 48.2%, but in that second-line setting, a response rate of 56%. We think those numbers are very meaningful. We are seeing activity within the CNS, and I think that in general in the field, there's a lot of excitement for these ADCs. It's because we think these are going to be impactful, not just in later lines, but also I think the potential to really replace platinum etoposide in the front line, perhaps a more convenient, more effective, better tolerated, more appropriate partner to immunotherapy, maybe T-cell engagers going forward. So ADCs, mark my word, will make a big impact in this disease. Question is which one and how, and that's something we'll answer over the next year or two. There's also a lot of interest in small cell lung cancer subtypes. While we hear a lot about this meeting about specific biomarkers driving non-small cell lung cancer therapy, we do not see that for small cell. But in work largely driven by Drs. Charlie Rudin and Lauren Byers, we do have now biologic subtypes that do define different behaviors. Our first foray into biomarkers, looking at transcriptional regulators, expression of these transcriptional regulators as means to differentiate different biological subsets based on the expression of ASCL1, NeuroD1, PAL2F3, or the absence of these in more of an immune-infiltrated subtype. And these do seem to correlate with long-term survival, long-term response with immunotherapy, but we're not quite sure how to best leverage these. There's an ongoing study by Dr. Ann Chang, the PRISM SWOG 2409, which is using the expression of these biomarkers to determine are there different maintenance strategies that could be more appropriate. While there's a lot of excitement around these strategies, I will mention for those of us in the clinic today, these biomarkers really are not used right now to guide therapy. It really is an all-comer approach, but we'll see if that changes over time. And so with that, with the last few minutes before we close on time, I do want to address some of the questions and answers. And maybe I'll throw some of these to Dr. Carlisle and to Dr. Flores. One, maybe Jennifer, I'll throw this to you. How might tarlatamab use affect outcomes in typical relapsed refractory small cell lung cancer with comorbidities like COPD or paraneoplastic syndromes? Do those come into play at all? I know in the early days of checkpoint inhibitors, we worried that use of that would bring out more of these paraneoplastic syndromes we see with small cell lung cancer. Fortunately, that wasn't the case. Any concern, does that factor into your calculus at all for T-cell engagers?
I think it's important to be aware of how common paraneoplastic syndromes are in small cell lung cancer and be kind of quick to address things that might look like Lambert-Eaton and have actionable medications to use. But I have not seen a higher rate of paraneoplastic syndromes using tarlatamab, including on the phase 1 trial, even at higher doses. At 100 milligrams.
Yeah, I haven't seen that either. I'm not sure that we would expect that biologically. You call out Lambert-Eaton or LEMS, I think an important one to keep in the conversation, something we can test for with anti-voltage-gated calcium channel antibodies, something we can treat with newer drugs, so something that's important to mention. Narjust, I'll throw this one to you. After progression, if patients progress on maintenance of atezolizumab and lurbinectedin, how soon can we start tarlatamab? Do we need to worry about any kind of washout there?
I think no, we don't have a lot of time with this disease. The short answer is no. I think assuring that the bone marrow has go to decent levels, we don't have to expect pre-treatment levels for the bone marrow, and that the patient has fully understanding of how different this drug is and how the side effects are very different. But I will not have a washout period. Will you?
Jennifer, this is a great problem to be in, but a question I get asked a lot. If almost no disease, or even just long-term stable disease, do you ever stop maintenance immunotherapy in that stage 4 setting?
I have patients 4 years on atezolizumab, and we keep on keeping on. Because if we lose control, I'm not sure we're going to get it back.
If it ain't broke, don't fix it, kind of an approach. Narjust, what about you?
I've never been in that situation. Unfortunately, my patients had disease progression for me to say, oh, we're just going to keep on it. No, I haven't. But if it's not broken, don't fix it.
We get asked this a lot, and I will say, if we look at the Keynote 604 study, which was a negative trial for OS, but just barely, that study was different in its design in that it only had 2 years of pembrolizumab versus atezolizumab, durvalumab, and Empower 133 and Caspian really were indefinite as long as it was tolerated and effective. And I think that would be the standard approach. I do have patients that have gone 5 or 6 years and really asked, can I stop this? And I don't take it personally. I think it's more driving in, coming in once monthly. And so on a few patients we have stopped and watched carefully and have been, so far so good. I don't know that we need it for everyone. But the real answer with duration of immunotherapy is probably true as it is in non-small cell lung cancer. It's probably patient dependent. I don't think we have the tools right now to understand when it is safe to stop, but it's certainly something that we want to look at. A few questions here. Jennifer, I think this one's very appropriate for you. Smaller centers lack these intermediate care units. And so can we do home monitoring with telehealth? Do patients really need to travel to tertiary sites? Maybe you could talk a little bit about the experience you had sort of substituting an intermediate center for inpatient monitoring. Can you remind us what that showed?
Yeah, so it's a good situation to be in, to have oncology-trained nurse practitioners run a 24-hour unit, so where we can check vital signs and ICE scores and appropriately admit patients only that need to be admitted. That was about 25% of our cohort, so we saved admission in 3/4 of patients. But that certainly requires both the facility and the trained practitioners to monitor that unit. In thinking about how to move tarlatamab to patients who may be in rural settings and not have access to this type of situation, I think we need to be smart about how we design trials and look at this, because the timing of CRS is around 14 to 16 hours after dosing. So can you dose a patient in the afternoon and have a visit in the clinic the next day? And really make sure they have an appropriate caregiver at home, a blood pressure cuff at home, a pulse ox at home. If they have, a setup where you trust that someone can take care of them if they get confused in the middle of the night, can we time when we give tarlatamab and when we see patients the next day? Would that be a way to move the needle?
I think timing is very important. I was talking to our fellows, because sometimes the fellows get some of these phone calls about dosing later in the day, so the adverse event happened during business hours. I think that's something we learned from CAR T. So I think timing is important now that we understand more when this happens. And caregiving, like the caregiver needs to know what they are looking for, what are the adverse events, because the patient may not even notice the adverse events, so the caregiver also needs to be aware.
I think this is a great, really important strategy. And sort of tangential to that, and I really want to hear both of your answers, if we think of everyone involved, pharmacy, APPs, hospitalists, who owns the escalation protocol if CRS symptoms worsen overnight? Jenny, are you getting that call?
I am not.
I am, and
no. Sorry.
It's harder to wake me up now. I will say, as the grays come in, I sleep through a lot of calls in the middle of the night, but that is one change. So what's the progress? Because CRS reliably happens about 12 hours after dosing. And so when we're dosed, if someone comes in, they get their labs, they're in the clinic, maybe my clinic's running a little behind, so maybe they don't get that infusion till about 1 p.m. 1 a.m., I'm getting that call like clockwork. And so, what happens in the middle of the night?
We have overnight APPs that manage both the heme and med-onc services. So they've had experience with CAR T and bispecific T-cell engager toxicity, and have kind of developed protocols for them to be able to give tocilizumab, increased dex, send patients to the ICU. So it's kind of cross coverage with providers familiar across heme and solid tumor therapies, I think has really helped.
All right, please give them my number. Let me know if they want to move to DC.
I also get the calls. We do have nocturners that are hematology oncology trained. So their nocturners are people that treat in heme and onc, but our protocols are the primary needs to be notified.
So you're also getting that call.
Yeah, I do get the page. I think it's ironic how it's expected to you to like wake up. It's like, then they just throw data at you and you're like, okay, let's do this. But yeah.
I mean, we had the phase 1 trial for tarlatamab from the very beginning under the leadership of Dr. Wanakoko. And interestingly, the protocol required, it was a dexamethasone-based treatment over tocilizumab. So we see higher rates of tocilizumab than would be suggested based on the tarlatamab use because of the heme coverage overnight. But that's a small price to pay.
Which I think might be a better strategy, but that will bear out as we go forward. Well, that brings us to time. I want to thank my colleagues for all their insights today, Dr. Jennifer Carlisle from Emory University, Dr. Nargis Flores from Dana-Farber, and thanks for all of you for joining us today. Have a great meeting.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by independent medical education grants from Amgen, Genentech, a member of the Roche Group, and Jazz Pharmaceuticals. To access all materials for this activity, visit peerview.com/PYJ860.